cancer pathologist and also served as honorary dental surgeon to the Governor of Maharashtra. Please join me in welcoming Dr. D.K. Daftari sir. We are also privileged to have with us three eminent experts for this session. First, immense pleasure in welcoming Dr. Anshuman Kumar sir, Principal, Director of Surgical Oncology, Dharamshila Narayana Super Speciality Hospital, New Delhi. Sir is a double gold medalist with extensive clinical and academic excellence. I extend a very warm welcome to you, sir. Can I have a huge round of applause, please? Next, may I have the privilege of welcoming Dr. Kavneet Kaur ma'am, Associate Professor, Department of Oral and Maxillofacial Pathology, AIIMS, New Delhi. With extensive expertise in head and neck pathology, molecular pathology, and neuropathology, ma'am has received several multiple national and international awards. It is indeed an honor to welcome you, ma'am. Now, may I take this opportunity to invite Dr. Vinay Hazare sir, former Dean and Professor, GDC, Nagpur. Sir is a renowned oral pathology expert with over 4 decades of academic and research contributions in oral precancer and cancer. Please join me in welcoming Dr. Vinay Hazare sir. I extend a very warm welcome to all our distinguished speakers and express my sincere gratitude for their presence today. Now, with great honor, I hand over the proceedings of the symposium to Dr. D.K. Daftari sir to kindly take the session forward.
Good afternoon, everybody. Before we start the symposium, it's my privilege to offer tribute to our mentor, Dr. Borges. You all know this September 18th was the cruelest day in our life. When we conceived the idea of symposium, she consented to be with us on this day. But unfortunately, physically we will miss her. But as always, she is a guiding light, inspiring mentor to all of us, I know. And this is what Indian Academy of Oral and Maxillofacial Pathology offers as a tribute to Madam Borges. You all know she did undergraduate studies and postgraduate studies from TNMC Medical College, Bombay, and was extensively trained throughout the globe, especially at Royal Marsden Hospital, London, and Sloan Kettering Memorial Hospital. Madam Borges established the Tata Memorial Traveling School of Oncopathology, where pathologists, technologists, and oncologists traveled across India to teach and improve the standards of oncology. An online teaching program twice a week for the past 5 years reached thousands across the globe as well. She was open to new ideas and maintained good relations with friends, students, and other professional colleagues. Madam Borges has attended mostly many IOMP conferences, and especially I remember maximum attendance, maximum speeches and lectures were at Belgaum when she discussed epithelial dysplasia, salivary glands, and what. This is one of the memorial photographs with her very best friend, our mentor, Dr. Daftari, after the Agra conference. This was the first oral dysplasia workshop held at London, and the madam was the sole representative of Indian delegation. And you can see that Professor Johnson, Samarvarna Pulasolia, and the entire global team who discussed oral epithelial dysplasia. In fact, my association with started at the 7th National IOMP conference at Nagpur when she delivered a keynote on the epithelial dysplasia. And believe me, these are all the original photographs. Madam used to say potentially malignant lesions and oral cancer are frequently encountered lesions in India. Yet, not much attention has been paid, maybe due to non-glamorous nature and monotonous regularity with which it appears in the oral pathology registry. And indeed, all of you will agree that Madam Borges has brought glamours in non-glamorous oral cancer field and especially the pathology throughout the globe. I told you Belgaum was the first and maybe many more occasions we met on different occasions. And you can see the audience, Raghu, our all friends from Inker and so many friends, Revti and all this. And teaching was her passion. She spent much of her time conveying ideas across the teaching and microscope as well as slide seminars and didactic lectures. I remember meeting him with Professor Johnson and Madam at Chennai where we had a heavy symposium on oral precancer. And of course, her philosophy, work like a pathologist but think like a clinician. This morning, Rajiv and Narayana has expressed gratitude towards Madam. And she has influenced not only Narayana, me or Raghu and Rajiv, but almost all who have come into contact with her. Master classes was her brainchild and she really delivered the last master class in this UP on 18th September 2025 and while delivering she passed away. Unfortunate day. We'll miss the madam. She was welcome at that Gorakhpur dental pathologist group and this was sent. And this is 32nd IOMP symposium. In fact, in 1991, Madam wrote the surgical pathologist and squamous cell carcinoma of the oral cavity a review. It was a Tata Memorial Golden Jubilee publications. Not many of us have the copy. But I thought I must reproduce the same with pathologists like Madam and the surgeons around us. And this is what today's symposium is in her memory and in its. So I have Dr. Daftari as the mentor for this symposium. Dr. Anshuman Kumar, another young dynamic oncosurgeon who works at Max Hospital now. And of course, we have Dr. Kaulik Kaur from AIMS. So this is what is the real happening today, even without the absence without the presence of Madam physically. Madam, I am sure all of us are definitely, Madam, guide us from wherever you are. And with this, may I request to stand for a minute in her memory once again. Thank you, sir. So, now coming back to our regular symposium. So to start with, words of wisdom from our mentor, Dr. D.K. Daftari. I invite Sir to express his words of wisdom to all of us. Sir, please.
Greetings to all of you. I'm happy to be here. Dr. Handare does touch Anita Borges. Now, Anita Borges has been a friend extraordinary. It was my pleasure, the privilege to bring Anita Borges into our fold as a general pathologist, but as an associate member. And she came to us and she absorbed oral pathology and the members of oral pathology in the full way. And similar was our respect and regards and love for her also. I'm sure she has touched most of the members here in a different manner. She was a Catholic, but a true Catholic. Humility was her forte, and I remember various time meetings. Anita Borges was a personal level in Bombay and elsewhere. And a person like that, let me put it this way, they don't make such people anymore. When you speak about Anita Borges, you got to understand one thing, that when I had to introduce her at one of these conferences, something like that. She comes from Tata Memorial Hospital during those days, and that Tata Memorial Hospital was situated in Parel. And I spoke there, that this lady from Parel has paralyzed all the doctors in Parel area. That Parel area had this GS Medical College, KM Hospital, Varia Maternity, Varia ICMR reproductive system, Hopkins, and everything which you think important enough from a medical point of view was situated in Parel. And it was not a humorous comment, but it was a fact of life that she did paralyze all the doctors from that Parel area. Now, one thing about Anita Borges that Dr. Azhar mentioned, that dysplasia. Dysplasia was one of the things we were discussing. But we were discussing many things which include ethics in the medical profession, and she was widely read. And as usual, we had a wide course of interaction in a different field of life. Ultimately, what counts in the life is not only medicine, but the people and how we take care of the people. And that is one of the key points of Dr. Anita Borges. And since he brought the point out, I think we have benefited considerably by her presence. I still feel, since I'm on the platform, that there can be many general pathologists who can become a member of our specialty as an associate member and can contribute towards our subject. When I'm on this platform, I'll be failing in my attitude of gratitude if I were not to thank Dr. Devi Charan Shetty and his team for an excellent arrangement, both at the conference, at the social level, and so forth. And I did not realize that Devi's Charan also was faster, like a mind space, as I saw it on yesterday's banquet. His feet were going like absolutely in an organized manner, more synchronized than his mind also. He has touched both our heart and mind, and I'm grateful to him, and I thank you and his team from this platform. And his consideration for others came out truly in this conference. I thank them again. Because when you're at the platform, I like to take that opportunity to do that. Right now, then we come back to what is my story, or sort of, and I thank that the symposium is on, still on my name. We are always discussing oral cancer, but I just brief you about my journey on the field of oral cancer. It's simple, but I felt it was important. Way back when after graduation otherwise, we used to hear a comment from paymasters and other doctors at Tatagar Hospital that they used to see cancers, oral cancer, and they always felt it was preceded by some white lesion. A simple observation, but the observation was sufficient enough for us to understand, at least for me and my colleague, a senior dentist, Dr. Fali Mehta, who was an intercessor to the Bombay policeman, for us to realize if everybody feels, I'm talking about 1958, 59 and 60s, maybe of those years, if somebody makes an observation of a person of a repute, that when he treats cancer, he used to remember that the cancer had seen some previous white lesion. So that made us bring about that why not follow a white lesion? And that is why for the first time we had this pre-cancer registry. And that pre-cancer registry then ultimately was decided that we work in the rural area where we follow the villages of India in its natural environment without telling them to give up stopping the habits. And that's how we formed a pre-cancer registry. Cancer registries are everywhere in the world, including in India. And that gave us a remarkable result. One of the results that I can talk to you is that about 21 to 42% of the pre-cancer with the continuous habit regressed and there was remission. So it eventually shows that there is a multiple small percentage of leukoplegias otherwise are going to cancer. We did not get a single case of cancer on a follow-up of over 50,000 people in those days for 10 years, which had no pre-cancer lesion preceding it. No de novo cancer came in. So that gave us indicated that relevance and importance of pre-cancer and at the same time importance of the habits. During that time at Delhi and otherwise, there was always a move to not to have a dental surgeon be involved in the ultimate examination of the oral cavity at the district level or otherwise. And we had to sort of bring it on the point that dental profession examines them all usually. You all examine them all casually. And we examine them all in a sufficient proper lighting arrangement. And we have understood normal mucosa because we have studied oral mucosa. And therefore, any abnormality of the oral mucosa shall be better be seen or treated or diagnosed by us. And that is how a dental profession or oral pathologists were brought into the picture. There will be a sort of a guiding or tipping point for taking the responsibility of oral pre-cancer cancer treatment. And I'm just giving you a background for you to realize it. We also mentioned that whether the histological preparation and the test that we're looking for may take a little time for you to get to examine the cancer. Also, he mentioned that we can revisit our patients. I want to urge that whatever we have done our studies, somebody can revisit such studies and figure it out whether we are right or wrong, reconfirm or reject us. But at the same time, today what is happening is that they are reporting that 25% of oral cancers occur in the mouth without habits. So it's quite important that this journey that we have was important enough even those days, because of 30 years of work and plus continuation, that WHO decided to give us a WHO collaborative center for prevention of oral cancer, and for the first time in the history, that an ordinary basic natural research unit center at PIFA got the accreditation. Now I'm only suggesting we have esteemed people speaking on the subject on oral cancer. I hope she is able to bring out the point and how many of such oral cancers that she's treated or seen from the data have been without habits, or at what level they have been seeing the oral cancer when they see a slide or when the case comes for a treatment. It's important us to know at what level a cancer comes at this early stage. We may not be able to reduce the mortality because that's a different world. But we certainly can reduce the morbidity that we see in oral cancer. And I'm glad that we are still bringing out the point of oral precancer cancer. And I'm one of the agitators. And I do believe that this is important for profession, more important for the public at large. I've been witness to the journey of oral pathologists in a big way. It's very impressive, it's very tremendous the way we are progressing. And I absolutely still saw the presentation, saw what everybody is thinking about. Every oral pathologist has its own journey, and the journey has been very fruitful to all of them and have contributed immensely in the growth of oral pathology. I compliment them also, and thank you all. And now we proceed with our part symposium.
Thank you, sir. May I invite now Dr. Anshuman Kumar. As you know, the title is Oral Squamous Cell Carcinoma, Surgical Pathologist, you. And Dr. Anshuman Kumar will speak the surgeon's perspective in this. Dr. Anshuman Kumar, please.
Good morning. Thank you very much, IOP organizers, and a special thank to Dr. Daftari and Dr. Vinay Hazare. I met Dr. Vinay Hazare accidentally in 2009 at Srinagar Dental College, right, sir? Yes. I was doing a live workshop operating head and neck cancer, and sir was in the auditorium. After that, I can't tell you. Sir invited me. I may be odd man out among the dentistry background because most of the people, when I talk about the head and neck cancer, they think that I'm from PDS graduate, but I'm a MBBS graduate. And in UK, from where I did my MRCS, PDS and MBBS need to be there to become a head and neck surgeon or maxillofacial surgeon. This is not common in India. Therefore, my topic, I'm willing to wrap off oral cancer. Surgical means cancer surgeon perspective, not the pathological, because you are the master. Yeah, as I told you, you all are learning people. There is no point of discussing, especially if you see, once upon a time there were three friends, one pathologist, one physician, and one surgeon, went to jungle to hunt a duck. When physician saw a bird, he asked, it can be hypertrophic pigeon or it can be hyperplastic hypertrophic sparrow. I had to give the differential diagnosis. Then it was turned for the surgeon. He pulled out the gun, shot it, and asked the pathologist, examine it under a microscope, what it is. That's the role of surgeon among pathologists. We are illiterate people among pathologists. Especially in the era of Google, when you find everything available in the 5G, especially artificial intelligence and chat GPT, what is the purpose of arranging this kind of annual conference? हमारे शास्त्रों में लिखा गया है विद्या मित्रम प्रवासी सुभार्या मित्रम गृहेश्च व्याधितोऽस्थं तं धर्मं तस्य च, जिसमें माइक्रोस्कोप पे बैठे होंगे सामने क्लिनिशियन खड़ा होगा, जल्दी रिपोर्ट दे दो, 5G will not work. चाणक्य ने कहा था पुस्तकेषु च विद्या पढ़स्तेषु यथा धनम् उत्पन्नेषु च कार्येषु नासा विद्या नाथा धनम्। पुस्तक में रखी विद्या दूसरों के हाथ में गया था, जरूरत पड़ने पर कभी काम नहीं आता है। इसलिए इस तरह के कॉन्फ्रेंस में जो हम इंटरेक्ट कर लेते हैं, that will remain lifelong. Especially when you are sitting in the chamber, now era is coming for personalized medicine and prevention. Remember, it will not be a kind of textbook medicine in future. For basic postgraduate and undergraduate student, when we talk about the cancer, there are a lot of definition. Even on definition, there are many books. Simply speaking, 30 trillion cells obeying law and order of the body is normal cells, and just few have become terrorists, start killing our own body, migrating from one organ to another, that is cancer. If you have to explain to the patient, patient will not understand your pathological language. You have to tell them basic language what is cancer. Second question patient will ask you, can we detect it? Is it possible? Yes. Just we need awareness of the individual, each individual and the doctors. There's a very good film, Specialist, and there was a repeated bomb blast in US after that. The bomb diffuser was told to suspect anything can be a bomb. Similarly, as a clinician, suspect any lesion in the oral cavity can be cancerous. Just we have to suspect. This was a slide that created a lot of ruckus when I was in an international platform. Indian oral cancer can be treated as per the Western literature. There were a lot of ruckus started. And after that, they were convinced that yes, Indian oral cancer is a different cancer, different entity altogether. The reason being, habit, smoking in the Western world, in our part, it's a chewing, especially betel nut chewing. Age, in their country, middle and elderly are the more common population. In our 18 years, 20 years young boy, they are presenting with advanced oral cancer. Sight, tongue and floor of mouth. Technically, we call it central compartment lesion. Tongue and floor of mouth more common in the Western world. In our part, it's a buccal mucosa or GB sulcus. Oral submucous fibrosis practically absent in the Western world. In our part, it's common and presenting more than 70 to 80% of the cases. Socioeconomic status, middle and high. In our part, it's low or middle class. Stage of detection, T1 and T2, 80% of the cases in the Western world. In our part, 72% presenting T3 and T4. National protocol, they have a strict and executable national protocol. In our part, it's absolutely non-compliant. Health insurance, government covers almost all NHS people. In our part, it's out-of-pocket expenditure. And load, my friend at Royal Marsden Hospital, UK, they operate 4 cases in a month. In my unit, I operate 8 to 9 cases per day. That's the difference in load. Therefore, Indian oral cancer is entirely a different entity, and we have to create our own literature, own database, and own set of clinicians from all the department come on a single platform and decide the protocol. As a dentist, can we contribute something? Simply speaking, prevention, early detection, you can reverse the scenario of detecting majority cases in early stage, availability of the treatment across the country, uniform national protocol, and improving ultimately the cure rate. There are a lot of contribution from your side is needed, because dental practitioner, usually patient with these symptoms present with the dental clinic, not the medical clinic. Therefore, you have good training to examine the oral cavity, you have good light and dental mirror. Therefore, it's a very high chance to detect precancerous and cancerous lesion. Examination of the oral cavity is still the best tool with the torch gloves and tongue spatula to detect the lesion, not the PET scan. And just meticulous examination of the oral cavity still detects majority of the lesion, lower lip, upper lip, buccal mucosa, hard palate, soft palate, dorsum of tongue, lateral border of the tongue, ventral surface of the tongue, bimanual palpation of the floor of mouth. That's all. And detects almost all cancer, even in the early stage. These are the risk factors: smoking, spirit, sharp teeth, sexually transmitted infection, and sanitation. But for the public, smoking and alcohol are the common, not all. Therefore, dental awareness, the dental health, oral health should be for the public domain. Tobacco, everybody knows, is a classical tongue cancer. This is a real picture of Delhi roadside. There's a beggar feeding gutka to a small baby. When I asked why you are feeding this baby, बताया कि बच्चा सोता रहता है तो लोग समझते बीमार है, पैसे देते हैं. मैंने जब पूछा कि बच्चा तुम्हारा है, क्यों नशा कराते हो, तो बोला बच्चा मेरा नहीं है, किसी कामकाजी महिला का बच्चा, उसकी मेड से मैं भाड़े पे लाती हूँ और घर लौटने के पहले वापस दे देती हूँ. दिस इज डेविल ऑफ द सोसाइटी. Cigarette, few of our doctor's friends, they smoke. Cigarette simply says we kill. They start before the kick of life, they are kicking their own life. Cigarette has almost 3,200 chemicals. Out of that, 70 are carcinogen. Sharp teeth are very much ignored in our society, and nobody is addressing those issues because nobody understands importance of chronic irritation, metaplasia, dysplasia, and carcinoma. Daftari sir was asking, human papillomavirus 16 and 18 especially, oral cancer, especially in female, no history of any dental treatment, no tobacco, no alcohol. I have collected 57 cases. Right now, I have talked to Hajare sir. Right now, I'm not disclosing the geopolitical area of that, but there are certain concentration of people who are involved in different kind of sex. There's unprotected oral sex. We are fortunately presenting with good lymphocytic response and very early stage. Fortunately, everybody operated cured, but HP all are B16 positive. This is oral hygiene, another problem. Oral lesion, simply baby cancer, pre-malignant, is not the topic of today, and it's a classical oral cancer presenting with either reduced mouth opening or any of the lesion like this, loosening of the teeth, or something like swelling. Patient was unaware that he is having some cancer. High index of suspicion. Always I ask the clinician, suspect, do the biopsy. Nothing harms doing, especially if the lesion is solitary and present for more than 3 weeks and you're given all kind of antioxidant treatment, particularly if it is indurated, cervical lymphadenopathy, and present in high risk group. That is 5S. The was saying followed white lesion. 60% of oral squamous cell carcinoma till 5 millimeter in size present just as a white lesion, no ulceration, because central necrosis is not there. And if you do biopsy of any of the white lesion, in 30% of cases that you find hyperkeratosis, dysplasia, or carcinoma in situ. Therefore, any white lesion, unless proved otherwise, must do biopsy. People are thinking of the FNAC and biopsy. There are certain myths, particularly in northern India. When I was in Gujarat, there is no such kind of myth. In northern India, people and patients ask, if we get biopsy done, it will spread. Cancer, once touched with the metal, it gets spread. This is a myth. Fact is, in entire oncology, only 3 situations, renal cell carcinoma, ovarian tumor, and gallbladder carcinoma. If it is operable on imaging, only biopsy is not needed. That's all. Otherwise, biopsy, if this means any kind of histopathology or cytopathology is required before going for any treatment. For oral cancer, scrap cytology is out. FNAC, very low yield. Excisional biopsy, don't do, never do. And incisional biopsy only for endocritic and submucosal growth. I personally propagated then what to do. Usually, people are either confused or scary phobic because of bleeding, and they are not opting for biopsy. Answer is punch biopsy. I have conducted more than 500 live workshops for biopsy. This kind of punch biopsy. Because in dentistry, whatever you are using, that is derma punch. The rotation, derma punch. That's not the oral punch biopsy. This is oral punch biopsy. Very, very user-friendly instrument. Even keep it in your clinic. No suturing is required. No chance of bleeding. Absolutely no chance of bleeding. Only you will face some kind of oozing, that's all. Derma punch will not give you enough tissue. Sometimes basement membrane is missing. Sometimes necrotic tissue is coming. This will give you enough tissue. What we require? One forceps, local anesthesia, punch biopsy forceps, and bulb. That's all. The lesion like this can be biopsied. Lesion like this can be biopsied. Even with trismus, you can take biopsy because no manipulation is needed. this biopsy under process. And after biopsy, clinician, I always request clinician, first label the bulb, seal the bulb, fill the form, keep this on the station, only then jump for the next biopsy, because there are always chance of mixing of the biopsy. After 3 days or 5 days, depending on the turnaround time of the pathologist, some report comes, necrotic inflammatory cells, some hyperchromatic nuclear absent, kindly correlate clinically. This appear actually something written in Chinese for the clinician. But majority of the time, I'll tell you, majority of the time, I'm always pathologist friendly. Majority of the time, pathologists are not wrong. Whatever they have seen under microscope, they will report. It's a clinician duty. If you are not getting the proper report, you are suspecting cancer, then senior clinicians should jump into the picture. Usually biopsy is being done by junior clinician. They should jump into the picture, take another deeper section of the biopsy. If at all required, take help of frozen section. That may be needed. Proper fixation of the specimen and proper labeling is important part. Biopsy form must be filled with proper details, along with clinical history and radiological finding. That is part of the filling of the form properly. There are certain problems what pathologists face after sample is being sent to the vascularization of the cell. Usually, clinician infiltrate local anesthesia inside the lesion. That should not be done. Usually, regional block is preferable. Squeezing artifact, they crush with the forceps. That should be avoided. Crush artifact, compression artifact, heat damage. Sometimes because of fear of bleeding, they usually use cautery or sometimes laser. They give heat artifact. Therefore, it's also not recommended. Autolysis artifact, they are putting in the normal line. And specimen to specimen contamination. Sometimes left out the specimen in the forceps or sometimes mixing of the specimen. These are the remedies, how to avoid it. I always ask for the clinician concept of 3M. First, man, that is Mazdoor, that is surgeon. Second is medicine, and third is machine. How to treat cancer? We have to treat. Being oncosurgeon, first we were taught what to cut. Then we were taught how much to cut. We learned after MCH when to cut, and after 10 years of practice, I learned when not to cut. And that's the most important lesson in oncosurgery, because it's unpredictable disease. As you have already said, sir, it has not read the textbook of oncology. Cancer is lawless. It's written in Bible. Everyone who makes a practice of sinning also practices lawlessness. Sin is lawless. Not localized to one organ. It's always hop and pop, jump from one organ to another. Always close to the major vital structures. This is the classical vital structures, and in those who have read the Quran, they must have. We have already created man and knows who his soul is whispers to him, and we are closer to him than his jugular vein, and we have to operate close to jugular vein and carotid artery. Tumor spillage must be avoided because that lead to exfoliation of cells, local recurrence, and local distal recurrence is failure of the surgeon, not the failure of cancer. In our philosophy, monster duct vision had a boon that even a drop of blood touches the earth, second monster will come. Same happens with the cancer. Therefore, local exfoliation of the cell must be avoided while doing surgery. First chance is always the next chance, and the last chance. Never feel that radiation and chemotherapy will compensate in properly done surgery. That is the last chance. It's always a multidisciplinary approach, and for dentistry, I always say, Tridev, oral maxillofacial pathologists, oral medicine radiology people, and oral maxillofacial surgeon. 3 departments get united, form a cancer department. Then your result will be absolutely beyond I can say Western literature. That I'm sure. Because we have a lot of volume, lot of training, and a lot of patients. Treatment modality, when we come, Hajare sir was asking, just glimpses of surgery. In 2 headings, we have to address the head and neck cancer. Only mandible and neck. What to do? For mandible, either segmental mandibulectomy, marginal mandibulectomy, and mandibulotomy. just for access. Segmental if it is involved, or paramandibular soft tissue involved segmental mandibular. Marginal, mandible is not involved, but to take the extra margin, we are doing marginal mandibular, but remaining height must be 1 centimeter. For PG, that will be the kind of MCQ, the remaining height of the mandible. And mandibulotomy for posteriorly located tumor, that's all. How to address the mandible. And for the neck, if it is N plus, neck is positive, obviously we have to address the neck. If it is N0, Mandel Hall criteria is there, when to address, when not to address. There are kind of neck dissection. We need not to discuss all kind of neck dissection. These are kind of neck dissection. Just glimpses of operation theatre, because why I'm saying now we are running surgical oncopathology fellowship for oral pathologists, and they have to come to the operation theatre, get trained, go to the department, the pathology department, molecular marker, IC, everything, and follow the patient in the OPD. Therefore, this is purely clinical fellowship. This is the classical position of the patient while surgery, padding, anesthesia machine. There are many incision type, and for last few years, I have modified the incision. Now you can't make out from the front that any incision is there, and we have published this paper. This is small lesion, laser excision, excised, especially on stack, because otherwise it's impossible for pathologists to tell about the margin. And this is carcinoma right lateral tongue, modified trial, excised, specimen, closure. This is carcinoma right buccal mucosa, small lesion. This is platysmal myocarditis flap. In 1972, Futtler started this flap, and after doing 10 flaps, he aborted this idea because no flap survived. And when I started doing this flap, the highest series was from China. They have done 11 cases. I started this flap, reinvented the wheel, and changed the technique. And now we have crossed 3,752 flaps. This is the beauty of India as far as the head and cancer is concerned. We have enough data. This is the classical dissection. This is the flap, platysmal myocarditis flap. And that can be done in trismus cases or kind of non-malignant cases because donor site is the neck, no extra morbidity. This is the donor site. Carcinoma buccal mucosa, intraoperative, specimen, overlying skin was involved, unable to close, clover leaf flap from pectoralis area, closed. Carcinoma leftodectomolar trigone, excised, specimen, reconsidered free fibular flap, post-op. This is the technique I use for labeling tumor primary and level of the lymph nodes. Along with, this is the I started, and in 2022, I visited Korea and explained this technique. They adopted this technique. Normally, if I send without marking, this is blue, green, blue, yellow kind of thing. If I'm sending pathologist a specimen, pathologist saying medial margin is suboptimal or 5 millimeter. Which part of the medial margin? From here to here is the medial margin, from where surgeon has to revise. If I'm marking this sample is going to pathologist, corresponding bed is marked with the same parameter, right? Now, pathologist is saying 5 millimeter from the junction of green to blue is closed. Then I know this is the area of representation. I can revise the margin on table, then and there. There's nothing to wait for the paraffin section, then flap is already united after 7 days. And ultimately, we have to give extra radiotherapy just for the positive margin. Therefore, this is the marking of the, and we have done thesis for the DNB, and this is a really good technique, and surgeons should adopt this technique that can help pathologists as well as surgeon and ultimately the patient. This is basal cell carcinoma of the nose, excised, flap, skin redness cell tumor, excised, closed, adenoid cystic carcinoma of the heart palate, maxillectomy, neck dissection, flap, parotid tumor, facial nerve preserving, osteosarcoma upper alveolus, excised, free fibular flap reconstructed, post-op, angiosarcoma scalp, excised, specimen, flap, squamous cell carcinoma pinna, excised, net dissection, reconstructed, pulmonary carcinoma thyroid, excised, this is specimen, closed. This was a guy from Nigeria, squamous cell carcinoma scalp being treated with chemotherapy because entire Nigeria was lacking oncosurgeon or any surgeon who can operate this. And when he came to India, consulted me, fortunately at that time, brain parenchyma was involved. We did craniofacial resection, excising all the calvarium, bilateral maxillectomy, both eyeball preserved, brain parenchyma preserved, and reconstructed with ALT-free flap. This is a carotid body tumor, excellent tumor for the surgeon because it's just like diffusing atom bomb. Either patient will survive or surgeon will survive. This is Chamberlain type 3, 10 centimeter tumor, excised. This is laryngopharyngectomy and nedis. Why I'm saying? Because being maxillofacial, oral and maxillofacial pathologist, you have to test all these kind if you are getting a specimen from the surgeon. This is a funny slide. After laryngopharyngectomy, usually we rehabilitate patient not to smoke. But this patient lost to follow and came to me with burn on kurta. I suspected he started smoking bidi. He refused. I also thought, how he can smoke? I have removed the larynx. He was smoking from tracheostoma. Therefore, rehabilitation is very important in head and neck cancer cases. This is robotic surgery. I don't think, just to give you idea how we do robotic surgery. This is surgeon's console. This one is surgeon's console. Normally, patient started asking, in robotic surgery, who operates? You or robo? Surgeon gives command. Sitting on the console, obviously we don't need to get a scrub, only assistant surgeon get a scrub. All command is being transmitted through LAN system. This is patient card, this is robo actual, and this is vision card. Whatever command is being given by surgeon's console, that's being replicated with fine movement. This is intraoral surgery. Carcinoma tongue going to base of tongue with trismus. Normally we need to do mandibulotomy to access the tumor, but with the robotic surgery, net dissection with a small incision, just pinhole incision, and this excision without any scar on the face. That can be done. Then after surgery, surgeon's expectation from pathologist, oncopathologist. This is lab requisition form. We have designed lab including all the details, whatever is mandatory for reporting the cases. We have designed that form. As I already told you, this is intraoperative consultation. This is not frozen section. We send a specimen as it is without formally to the pathologist. Unbiased surgeon right on the margin, that's, for example, medial I have taken 1.5, lateral 2, something like that. And unbiased, pathologists give their margin, is it suboptimal, means sub-centimeter or not. If it is not sub-centimeter, they take frozen section from the closest margin, means 1.5, 1.8, 1.7, then from 1.5, pathologist will take the margin, supposedly closest among all. But that should not be closest, should not be sub-centimeter. If it is sub-centimeter, revise the margin. That is the whole idea, that intraoperative consultation. Cross assessment of the fresh specimen, not formally fixed, already told exact margin assessment, precise feedback to the surgeon for margin revision if needed. I always ask pathologists, raise my bar. You challenge me that I am taking less margin. You challenge me always. Frozen section from the smallest denominator amongst the margin. Surgical oncopathology fellow bridges the gap. Fellow remains in the OT and they follow the specimen, go to the lab. Fellow actually know both the sides, surgeon side as well as pathologist side. Advantages are precision in surgical margins. Real-time and real-site update, unbiased assessment from surgeons and pathologists. No surgeons press a letter on to revise the margin. In private practice, usually surgeon prescribes pathologist to revise the margin. It's not closed margin, just write 1 millimeter at least or 5 millimeter minimum. Therefore, if you follow this protocol, no need to undergo pressure of the surgeon. On-table revision of margin before flap surgery. Final correlation with the paraffin section must be done, and overall improved result. That's the whole idea of doing intraoperative consultation. Surgeons have been not just write well differentiated commercial carcinoma. It's always well described in a written report as per any standard format. We follow College of American Pathologists, covers TNM, lymphovascular invasion, margins, lymph node status, especially ratio of metastatic lymph node, molecular markers, P53, Ki67, something like that. We follow this kind of pathologist. She is Garima. She is my first oncopathologist, done fellowship. When we talk about the need of India, when we start from Delhi, Delhi is not India. In India, is 30% of all cancer are head and neck cancer, and as I told you, majority are in low socioeconomic class. And real fact, majority of the public, 70% of the public hospitals, they are lacking basic dental chair and dental examination setup. We have to fulfill that. Oncologists, 2,000 oncologists for 10 million patients. It's not possible for oncologists to cover all the cases. Therefore, we have to recruit dentists. Health budget, after independence, India is having just less than 2% of GDP as health budget. Therefore, health budget is even not sufficient. Failure of national policies, we have published a paper after tobacco ban in Delhi and Uttar Pradesh. Cancer cases still rising. That was simply eyewash, no actual ban. And the reason for that failure was corruption and non-inclination of the Indian government and non-compliance of the execution authorities. Chemotherapy and consumables are Ayushman Bharat versus drug price control. Drug price has not been controlled, therefore there is a lot of failure, and after multiple pressures, now 492 drugs have been capped, cancer drugs. These are the chemotherapy menace, where chemotherapy was not needed, being given because of vested interest by the oncologist. Their comprehensive cancer care contribution towards cancer care must be there, and Baba therapy must be stopped. Some Baba treated with Gomutra, the cancer care. And these are the cases of Baba therapy, neglected cases from Baba therapy. Therefore, my recommendation to the entire, because you all are policy makers, dedicated cancer center, uniform national protocol, regulation of Baba therapy and its kind, drug price control, decentralization facility across the country, moral responsibility in Indian oncologists, recruitment of the specialty for early detection, media involvement for healthcare, and increasing health budget. That is all the whole thing. When we talk about the cancer, everybody is afraid. Cockroach from rabbit, rabbit from mouse, mouse from cat, cat from dog, dog from men, everybody knows. And she again from cockroach. Therefore, don't get afraid, cancer doesn't recur. It's a myth that cancer is a big surgery done by a big surgeon in a big hospital, just required proper planning, optimal setup, and skilled hands. It's just need integration of the many branches to come together. When we talk about the patriotism, somebody says Bharat Mata ki Jai, Bande Matram, Gaurakshak, Gaubhakshak. When we talk about the religion, Mandir, Ramjan, Sunday prayer, but doctor, it's only one line, one thought, one community, Seva Parmo Dharma. Doctor is the most patriotic community of the world. Just by detecting early, we save lives, we save nation's revenue. Therefore, don't ignore your power. Surgeons' ergonomics must be there. Majority doctors are losing their spine and getting, these are the problem. In my setup, all my students, they work, before going for work, they do yoga, pranayama, and in between, we don't spend our time on mobile. We meditate for 10-15 minutes to cool our motor down to go for the next case. We don't have chair inside the operation theater. We sit squatting on the floor so that all kind of posterior spine muscles get stressed and we are rejuvenated for the next case. This is my team. This is Bridging the Gap. Dr. Hazare was saying, program initiative, must you talk about the program. This is Parth. There's a program initiative run by me. There's a CD, one-day workshop. Drone, this is a one-day crash course for BDS. Cavalier, that is stewardship program for BDS intern for 21 days capsule. Many of the NCR colleges, they are doing this program. So is 6-week observership program. Dr. Kanti is there. She has done for kind of biopsy, laser technique. Those who are doing practice, they can customize their module, what they are facing problems in dentistry. Nirvana is a program, 1 and 2 year dedicated full-time program for oral maxillofacial surgeon, oral maxillofacial pathologist, and oral medicine and radiology people. There are 3 programs we have been running. And Sarthi is a patient navigation system. Me and Dr. Vinay Hajarde started the program from dental chair to operation theatre and back to dental chair. It's entire patient navigation. Never patient will feel that he is being unattended anywhere at any point in time. This is Sarthi. Samarpan is another program, 3 to 7 days. We did on World Cancer Awareness Day in month of February. And this is Sangeet Se Swasth Cure, another program done by cancer survivor, especially oral cancer, this thing in the program. Samvedna is another program that's purely different other than cancer. People call me as a chief trainer for type 2 diabetes, hypertension reversal, obesity reversal program. You have seen, sir, this program. And Samakra is holistic wellness program, in-house, 5 days retreat for complete wellness. There is a physical wellness or mental wellness. This is my last slide, especially for doctors. जो मिल गया उसको इज्जत नहीं देते हैं, जो नहीं मिलता उसके लिए रोते हैं. उन्हीं के लिए मैंने लिखा था, जो मिल जाए वो मिट्टी है, जो पा न सके वो सोना है. निर्मल मन हो जा रे मानस, सब कुछ एक दिन खोना है. माया और प्रपंच भवन में निर्भर किस पर होना है, कर सको कुछ कर लो बंधु, दिन तेरा रोना है. पीछे छोड़कर रिश्ते नाते पंच तत्व में जाना है, राम नाम का बीन बजाकर बस स्वाहा हो जाना है. फिर भी उलझन क्लिष्ट जीवन और तेरा कटु व्यवहार, चित्त भेदती हृदय चीरती तीक्ष्ण रोषण नरसंहार. समाधान क्या है? सरल सादगी जीवन यापन, नित्य ना हो बारंबार, प्रेम भाव दया कर्म सहिष्णुता और परोपकार. प्रकृति स्नेह मधुरवाणी संतुलित और सरल विचार, मझधार ना आएगा आगे, हो जाएगी नैया पार, हो जाएगी. ओम सर्वे बंधु सुखिनः सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्ति मा कश्चित् दुःखं.
Thank you, Anshuman. How multifaceted personality Professor Anshuman Kumar is, and he has really given us the Indian scenario. Indian oral cancer is different. We have to tackle with our own indigenous, holistic way. And he has again re-emphasized prioritizing oral pre-cancer, various fellowship programs to make oral pathologists competent, and navigation system. Definitely all these will be recorded and published in our symposium. So thank you. Thank you. May I invite Dr. Kaulit Kaur for her presentation on the pathological aspect of the oral squamous cell carcinoma.
Thank you, organizers, for inviting me for such an honorable symposium. I thank Dr. Gambhir, Dr. Hazare, Dr. Deepika, and it will be an honor for me to stand among the specialized oral pathologists to talk about, and among oral surgeons to talk about the oral pathology. So as Dr. Anshuman has said that pre-malignant lesions and squamous cell carcinoma are different from Western world because we have a lot of different risk factors, and the pre-malignant lesions are also pretty different molecularly as well as clinically. So to understand them and to pick them up in a dental setting, that will be, I think, the future of head and neck cancer in India. So we'll discuss about the incidence of oral squamous cell carcinoma. I don't think so we need discussion on that, everybody knows. Then we'll talk about some OPMPs because that is the beginning of oral squamous cell carcinoma and that cannot be different from, that cannot be separated from squamous cell carcinoma. And then we'll talk about reporting in routine practice, staging, prognostic parameters, the recent advances in molecular as well as digital pathology and AI. So what is oral squamous cell carcinoma? It is the most common type of head and neck cancer and most common cancer in India, ranking 16th in the world. And India accounts for 30% of the squamous cell carcinoma burden. And it is expected to rise by 40% by 2040 if the risk factors are not curbed. So India is always the darkest and has highest rate of oral squamous cell carcinoma and it has the highest mortality. Other countries do have a higher load, but the mortality is highest among India and the patients present with higher stage squamous cell carcinoma and not early stage. So let's talk about oral potentially malignant disorders. So OPMDs refer to a group of lesions and conditions characterized by a variably increased risk of developing cancer. So why they are called potentially malignant is because not all patients diagnosed with these abnormalities will develop malignancy. And nor does it imply that the carcinoma will arise at the exact same time, exact same area where the OPMD was there. So the idea of field cancerization should always be taken into account in conditions where there are risk factors for development of oral carcinoma. And discrepancies in describing these disorders are still found in literature, leading to inconsistency and a degree of confusion. So the role of the pathologist comes that to classify these lesions and add insights for the surgeon so that it can be risk stratified and it can guide the surveillance strategies and try to incorporate molecular techniques in your routine practice. So what do clinicians look for in a pathology report? Diagnosis. Then certain terms the clinician should always look for, that when we are not able to give a proper diagnosis in an OPMD, but certain terms should be looked for by the clinicians, and more objective criteria and what molecular they should look for. So OPMDs have a variable risk of progression, as I said. The clinical terms are erythroplakia, leukoplakia and erythroleukoplakia. So I think whenever we get a form filled by a surgeon, it's our duty to call them back and ask what kind of lesion is it, how long has it been. So your form should have each and everything written so that you get a filled form and later you can always associate your findings with the clinician's findings. And it should not only be erythroplakia, leukoplakia and erythroleukoplakia, the exact size, the verrucous lesion, the non-verrucous, the proliferative, the indurative, all those findings are very important. Because all of these lesions, when we get an exophytic part of the lesion, we are not able to give a diagnosis and we keep asking for repeat biopsies. And we say kindly call it aclinically, as Sir said. But I'm mentioning that because we can guide the surgeons on which area to take the biopsy from, which lesions are more, which can be solved by repetitive biopsies, like the case of verrucous carcinoma. You can guide the surgeon in a comment. This could be a verrucous carcinoma, but we need a wedge with an adjacent shoulder of the epithelium, right? So always a comment or a rider, when you have the clinical information and the pathology is not matching with what you have got the clinical information for, it's always our duty to either call the clinician or write in a comment that what kind of biopsy are we expecting, that if it is clinically and radiologically a carcinoma, this could still be a carcinoma. So repeated biopsies is not always the answer. It's always the correlation between the clinical, because we are talking about a single patient at this point, the surgeon, the radiation oncologist, the radiologist and a pathologist. So it's always a good idea to call your clinicians and figure those things out. So what are the other OPMDs? Proliferative verrucous leukoplakia and dysplasia have the highest risk of progression to carcinoma. The others have a variable risk. And submucous fibrosis is more of a clinical diagnosis than of a pathological diagnosis. Then there are other certain autoimmune diseases like oral graft versus host disease, lupus erythematosus, then familial cancer syndromes like Lee-Fraumeni and all that. Those also come in this thing. They also lead to cancer formation, but in variable rates. So, risk of progression, higher grades of dysplasia have a higher risk of progression, and proliferative verrucous leukoplakia, which is not reported so widely, but it's in WHO 5th edition, and there are many papers which are suggestive that more than 40% of the patients with progressive form of PBL do progress to carcinomas. So what is a PBL? It's a multifocal, persistent and progressive. So PBL will not always arise as a multifocal lesion, right? It can start as a single lesion and then multiple lesions can arise. So to pick it up at an early stage, that should be the ideal way. So initial lesions are often indistinguishable from oral lichen planus or oral leukoplakias. And when there are multiple non-contiguous lesions, that clinicians should be able to tell us how many there are. And if the lesion size is more than 30 mm, then we should start thinking of PBL. They have a higher rate of recurrence, a high rate of progression, as high as 40%, and they are more in older women and absence of the usual risk factors like tobacco and alcohol. So the early lesions, they will look like that. These are the early corrugated hyperkeratotic lesions. From the name only we can see that they have a corrugated surface and they have a thick compact hyperkeratosis which is more than the thickness of the epithelium, and there is a thick band of lichenoid reaction. And the adjacent epithelium, there will be an abrupt transition. Then bulky epithelial proliferation. Bulky epithelial proliferation, you will see an endophytic squamous proliferation, and clinically it will look very verrucoid because you are seeing some sort of endophytic proliferation with hyperkeratosis. So both these lesions are very important to pick, and you should always do a PAS-D stain in any oral lesion to first exclude the causative agent Candida. So if you exclude Candida, because Candida is a treatable cause of all the oral lesions. So if you exclude infections, Candida, those sort of things, and you can write a rider that treats the Candida, because Candida can still occur in a PBL or a squamous cell carcinoma. So you can write a comment that kindly treat the patient for candidiasis and do a repeat biopsy if the lesion persists. Then comes the oral epithelial dysplasia. I think that everybody is very well versed, and so a spectrum of architectural and cytological features should be considered for dysplasia, not only cytological features. And it has a higher risk of transformation, especially the moderate to severe dysplasia, which ranges from 3 to 50%. So it's divided into three grades: mild, moderate and severe. The previous thought process that lower third and 2/3 and full thickness is mild, moderate and severe, that is no longer the norm. So it depends upon the degree of cytological atopia, the degree of architectural atopia, whether it's in the lower third, whether it's in the middle third or in the upper third. So those degrees make it into mild, moderate and severe dysplasia. Then there is another thing which Sir also mentioned, that HPV associated oral epithelial dysplasia is also present. HPV is not only in the oropharyngeal tumors, although in India we have a less incidence than abroad, but HPV associated oral epithelial dysplasia should also be looked into, and HPV associated oral squamous cell carcinomas are also there. How does it look different from the usual dysplasia? They will have a more baseloid morphology, more blue looking, and we can do P16 as the preliminary marker, which will show block-like positivity, and then which can be confirmed with the RNA-ish. So this is, you will see some viral cytopathic effects along with the baseloid nature of the dysplasia. When you see certain baseloid tumors or such dysplasias in the adjacent epithelium, you can go ahead and do a simple P16 which shows block-like positivity. Then submucous fibrosis, again it's more of a clinical diagnosis, but that also has a higher rate of conversion to a carcinoma. And this is a later stage where you see hyalinization, especially the subepithelial location, loss of vasculature, the loss of rectal ridges with epithelial atrophy. So those findings have to be mentioned clearly, and clinical should always be sought that there is submucous fibrosis and not some previous surgery or something which has caused fibrosis. And along with the clinical context, you can give a diagnosis of submucous fibrosis. Then certain tobacco-associated lesions should also be picked up, like smokeless tobacco keratosis, which have a high degree of conversion to carcinoma, and for lateral lesions associated with reverse smoking.
So terms to look for the clinicians in descriptive reports in which they should repeat a biopsy, or you should always mention them. Downward epithelial proliferation, when there's a lot of endophytic or exophytic squamous proliferation, always we should ask for a repeat after treatment of candidiasis or other infections. And if the lesion persists, if there is marked hyperkeratosis, if there is deep keratinization, if there is cytological atypia, and if there is lichenoid tissue reaction, because lichenoid tissue reaction occurs in PVL as well as lichen planus, and lichen planus also long-standing, if not diagnosed properly, is a high risk for, not high, it's a variable risk for carcinoma. So what are the challenges in pathology? Histological diagnosis of dysplasia is subjective in nature, imperfect predictor of malignant transformation with a myriad of mimics, because patients use everything, so many things in the oral cavity in India, all the risk factors along with dental implants and everything. So diagnosis requires clinical and pathological correlation, often requiring multiple biopsies. And AI and prognostic molecular markers may help to address this. So what are the recent advances? That in PVL, there have been certain molecular findings that DNA methylation patterns are different in PVL, and certain molecular markers like PARP are present. There's loss of PARP in PVL. And then we all know about dysplasia, that there are P53 mutations, loss of heterozygosity in certain this thing. So these can be used in fish, and those sort of lesions can be detected by detecting the aneuploidy using IHC for P53. So whatever resources we have, we can use those to identify these sort of changes. Then artificial intelligence, I mean, it's not available for oral potentially malignant disorders, but I think there is a huge gap in which there is a lot of subjectivity among pathologists, and this should be looked into. I think a lot of studies are ongoing, but not very specific, nothing has come out of it. Now coming to oral squamous cell carcinoma, it has varied clinical presentations. It can present as a non-healing ulcer, indurable lesion, or proliferative growth, and small undetected primary with cervical lymph node metastasis. So pathogenesis is all the risk factors which have already been talked about. The subtypes of SCC are important because they are prognostically different. So it's not only always well, moderately and poorly differentiated squamous cell carcinoma. There are different subtypes of squamous cell carcinoma. The first is the cantholytic SCC and adenosquamous SCC, which can be differentials of each other. So cantholytic SCCs will show cantholysis with same type of cells which are immunopositive for P40 and producing intracellular keratin. So they form pseudoglandular appearance. This sort of SCC has poor prognosis, so in biopsies as well as dissections, it's important to mention that there is presence of a cantholysis. In what percentage of the tumor a cantholysis is present. Then adenosquamous carcinoma is again more aggressive. It is associated with worse prognosis and more frequent metastasis. So adenosquamous carcinomas are the ones which have a mixture of glandular as well as squamous component. Mostly the superficial component is squamous and the lower part is adenocarcinoma. The other one is spindle cell squamous cell carcinoma. So when you get a polypoidal mass in larynx or in the oral cavity, specifically in those conditions, spindle cell SCC has to be kept in this thing. The other tumors which have a better prognosis are carcinoma cuniculatum, papillary SCC and verrucous squamous cell carcinoma. These are very difficult to identify on biopsies. So if a surgeon is saying, or a radiologist, that there is erosion of the bone and you are seeing well differentiated islands, so you can suggest that there is a possibility of carcinoma cuniculatum in such settings, and they generally do not metastasize and have a very good prognosis. Again, similarly, as I told for verrucous carcinoma, and then papillary squamous cell carcinomas are diagnosable because they have dysplasia in the exophytic squamous proliferation. We do not need invasion to call something a papillary squamous cell carcinoma. The ones which have similar prognosis are basaloid squamous cell carcinoma and lymphoepithelial carcinoma. So this is a basaloid squamous cell carcinoma. So in these sort of cases, P16 should be done to rule out HPV-associated squamous cell carcinoma. Then comes the spindle cell squamous cell carcinoma, which we should have a high degree of suspicion. And most of the spindle cell lesions which arise in the oral cavity, the first diagnosis is spindle cell carcinoma. Then this is a cantholytic, which is like pseudoglandular spaces, and these are the and this is a pictograph of the adenosquamous carcinoma. So after the diagnosis is given, for the microscopy, the first, and for grossing, the first thing is to know the staging. Once you know the staging, grossing is like extremely easy. So for staging, what we need is the size. So the size parameters are less than 2 centimeter, 2 to 4 centimeter, and more than 4 centimeter. The second thing which comes is depth of invasion. So what is depth of invasion? It's different from the thickness. I think now everybody knows it has been in use in HSCC since 2018. So depth of invasion is from the adjacent basement membrane. So you need the adjacent shoulder of the epithelium. But in India, what we get are mostly T3 and T4 tumors. So it is very difficult sometimes to give the proper depth of invasion. So in that cases, the maximum depth can be put in 2 blocks and it can be marked with a paint or something like that. So depth of invasion is less than 5 to 10 and more than 10 millimeters. So the residents should always know the staging before picking up any specimen, whether head and neck, whether any other specimen. And then what is important is the size and depth are T1, T2, T3. T4 in any area of the body, it's always about extension of the tumor beyond this thing. So if the size is very big, that is more than 4, more than 10, or it involves the bone, or it involves the skin of the face. And T4B is masticator space involvement. Masticator space includes 4 muscles, so grossing of those muscles is also very important. Pterygoid plates, skull base, or internal carotid artery. So bone invasion is something which becomes difficult many a time. So bone erosion, cortical bone erosion should not be considered as T4A. It's only when the medullary cavity of the bone is involved, then only we call it T4A. So that is very important to remember, because most of the gingival primaries will show cortical bone erosion. So that has to be kept in mind. Then the lymph nodes, the level of the lymph nodes should always be mentioned. Most of the times the surgeons send us, they make our job easy and send us in different containers all the levels, but if it's not, then it's important to identify with the help of sternocleidomastoid, the other muscles, the level of the lymph nodes. And then in lymph node staging, first is the size and the number of the lymph nodes, then is ENE present or absent. That is considered an end stage. But beyond present and absent, it is very important to tell the exact ENE. And whether it's microscopic or macroscopic, it's very important to write the exact distance. Because many papers say when it's more than 4 mm, that is the associated with much worse prognosis. So how do you measure the ENE? You form a line along the capsule, which seems like the capsule from the rest of the lymph node, and you draw a perpendicular line and measure the extranodal extension. So sometimes it's difficult to identify ENE, but once sort of desmoplasia starts happening, that means the tumor has gone beyond the capsule and it is lying within the extranodal tissue. So this is what ENE looks like, ENE nature. So the staging, everybody knows. Then what are the prognostic factors? So well, moderately and poorly differentiated do not always correlate with the lymph node stage and metastasis. Although well does correlate, but not moderately and poorly differentiated. So there are a lot of prognostic factors which have to be informed to the treating clinicians, including oncologists and medical oncologists and radiation oncologists, which includes depth of invasion, which we all do. Then what are the other parameters? Other parameters: invasion, tumor budding. If you go systematically, these automatically come that on low power you measure the depth, and when you see the pattern, and you see when you go on a little higher power, you see the lymphocytic host response, and then you go on a little higher power and you start looking for PNI, you start looking for LBI. So when you go in a systematic order, it automatically comes and you don't need to spend any extra time on the slide when you are looking at a squamous cell carcinoma resection. So depth of invasion, which are of high value, worst pattern of invasion when it's specifically 4 or 5, PNI, LPI, close or involved margins, and EME. These are the maximum value high prognostic parameters which have to be mentioned in the report. So depth of invasion is basement membrane to the deepest invasive tumor front. So if you're not able to measure the maximum depth, it's going in the bone and the section is not coming, you should always mention that it is at least this much millimeter. Don't tell me this is 5 millimeter only. Say at least 5 millimeter. Beyond that, it is not able to assess the further depth of invasion. So this is how we do the depth. Draw a line from the adjacent epithelium, from the basement membrane, and then draw a plumb line. Even if the tumor is exophytic, you won't take the exophytic component, and even if the tumor is ulcerative, you will include the from the adjacent depth. That means the tumor has eroded and formed the ulcer into the deeper parts of the tissue. Then comes the pattern of invasion. Pattern of invasion, WPO5 is the most important. So what is type 1? Type 1 is a cohesive broad pushing. So anyway, when you start seeing resections, you know that if a tumor has pushing margins, there will be less lymph node metastasis. So it is important to mention these things in report. Type 2 is broad pushing finger-like. Type 3 is invasive in large tumor islands. Type 4 is when it's small tumor islands, less than 15 cells, including tumor budding. And type 5 is when it's more than 1 millimeter. So CAP guidelines say type 4 and 5 have to be mentioned in the report. So this is the type 5, which is more than 1 millimeter with the normal tissue in between. So these are associated much more with the LVI and much more with the lymph node metastasis. Then AJCC also mentions that one has to mention the strand-like pattern of invasion in addition to other patterns of invasion. Then comes the tumor budding. Tumor budding is a sign of epithelial mesenchymal transition because the cells start invading in single cell forms. Then comes the tumor lymphocytic host response, whether it's band-like, dense, patchy, or it's sparse. That also has a prognostic correlation. Then PNI, it's very important to report because it has association with all the prognostic parameters. So reporting PNI is very important, and not only PNI present or absent. It has to be mentioned whether it's unifocal, multifocal, small nerve, large nerve, the diameter of the nerve, intratumoral, extratumoral, as well as whether the tumor is intraneural, that is within the nerve and not only in the perineural. And lymphovascular emboli, again, it's very important to differentiate lymphatic or vascular emboli. Vascular emboli will have a smooth muscle wall or an internal elastic lamina, single or multiple, intra or extratumoral again. Then Brandlin-Gensler histological risk score correlates pretty well with this is one of the risk scores which includes almost everything, and we use it in our reports regularly. Then neoadjuvant chemotherapy response. Nowadays, neoadjuvant chemotherapy is given for many early stage tumors, so that response is very important. And this is one of our standard which is used, which is Japanese criteria, which goes from grade 0 to grade 3 with no effect to marked effect. So those are all the data elements which we report. And then synoptic reporting format is very important, that at the end of your report. And also in addition, if you find some other prognostic parameters, you find other things which tumor-tumor ratio, you want to add other things which are upcoming, you should always add those in your comment, because later on we never know which becomes the most important prognostic parameter. Then at the end there should be a synoptic format which comes in the summary and which includes the data element and response format. So what are the recent advances in oral SCC? That, we are done with the reporting of SCC now, but the more recent advances include the molecular parameters like mutations in Notch pathway and TP53, and in HPV-associated squamous cell carcinoma, P16 overexpression, as we have already discussed. The other molecular biomarkers which can be done in routine, one of that is CDKN2A by FISH. If there is homozygous loss in a biopsy, that suggests that it's a malignant process. So that can be used in routine, and also CCND1 amplification. These two can sometimes help in repeated biopsies. Then saliva, blood and brush, minimally invasive biomarkers are being developed. Cell-free DNA, if there is high mutation load in cell-free DNA or in exosomes or in CTCs, then it's associated with recurrence of tumors. These markers are upcoming. This is a list of the recent advances, which includes tumor microenvironment, as Dr. Jaibi, I think, had told in the morning, about CAFs and tumor-associated macrophages. And then another thing which is different in the new AJCC 9th edition, that is about the minor salivary gland neoplasms which do occur in the oral cavity and are many a time seen. They are now not to be staged as oral squamous cell carcinomas. they have to be staged as major salivary gland tumors. So depth of invasion and all has not become irrelevant in minor salivary gland neoplasms. So many benign and reactive conditions occur in oral cavity and they mimic malignancy clinically as well as on histopathology. Oral squamous cell carcinoma is one of the most common cancers, and salivary gland tumors have to be kept in differentials when it looks different. And adequate tissue has to be taken to make diagnosis and prevent misdiagnosis. And it requires a structured reporting, and DOI, ENE and margins guide treatment decisions. And new upcoming are AI, cell-free DNA and exosomes. And immunotherapy, of course, PDL1, especially the DACO clone is being used for guiding immunotherapy, and early detection is the main thing. Thank you so much.
Thank you, Dr. Kaur. And also, as I told you, all these proceedings will be recorded in symposium proceedings of 2025. Previously, we had symposium on oral submucous fibrosis, so I have a pleasure of inaugurating or distributing the symposium proceedings of. Can Punya come in to that, please? We are running short of time, that's why this is a 1-minute program. In 2023, Rajiv, please join us. 2023, the symposium was on oral submucous fibrosis. Many of us have done that symposium proceedings, and Dr. Punya and Dr. Karishma have come out with the beautiful editing, and which is going to be released now. And may I request Dr. Daftari to release the proceedings on 2023 Oral Submucous Fibrosis Symposium. Dr. Daftari Symposium. Madam Sounit and Anshuman Kumar, please join us. Thank you so much. And now the concluding part, of course, I take it as it was introduced by Dr. Anshuman Kumar. We have come out with a group called Sarthi. Dr. Anshuman Kumar, me, and all of us are really the navigators in cancer journey of a patient, and that is what is the concept which I have briefed just now. And maybe we have in the near city of Ayodhya, and all of you know that during journey through the river, God was held by Kevat, and Kevat is an excellent skillful navigator. This is the concept. Even God needs the expert to cross over from the one bank to another. There are certain things which we learn during storms only. Like Dr. Narayana has taught us titanium storm, and we have worked on it. But when the patients are suffering, cancer patients they are really in a storm-like situation. So we need to navigate them properly. This is the concept. And cancer begins and ends with the people. This is one of the few textbooks written by Professor Prabhu, and excellent books overall. And cancer is a lifestyle disorder. As we have seen, Dr. Anshuman has explained the ways to treat the cancer in holistic. So this is when 1997, we started with a small center at Nagpur. Our powerful minister now, Gadkariji, inaugurated it. And this is what the journey of 30 years almost. I will share few of the life stories of the patients whom I have navigated since 1997. So this is the lady came to me when she was about 56, 97. This was the first patient, and no habit, tongue lesion. Of course, all of us are aware now. And she, of course, was operated at a very late stage 3 stage by Anil Cruz. And then radiation. And 2014, she was suffering from breast cancer. Post-COVID, we lost her husband. In 2021, she had a metastatic breast cell carcinoma, chemotherapy, and still going on. So this is how she is living a satisfactory life with a simple. So this is what is survival instinct. This is the real photograph of our conference in 1997. She is speaking at a group of all of us as a survival patient. In, of course, 2014, see how the follow-up has to be closed up by all of us. This is the concept. And how Madam has helped, even during the pleural effusion, people were, not having any particular diagnosis. So the slides were referred to Madam Borges, and that was the adenocarcinoma. So besides pathology, Madam has also taught us the empathy. This is recently post-metastasis, and met him and learned quality of life. Yes, Professor Anshuman Kumar has really devised very good modules. So all those 5-6 modules one must practice, including this Sarthi module. And this is the second case when I say a small patch. It was a high-risk dysplasia, follow-up, operated by, but non-healing ulcer, which constantly keeps bothering to us, was also bothering to the patient. He came out, and then we, of course, with the help of Dr. Dikru, we have overcome the disease. There are excellent oncosurgeons throughout India. We are really benefited. Though our cancer load is high, our cancer surgeons are really quality surgeons. Whether I was talking to Dipto, this Calcutta, excellent, Bombay, now NCR part, Anshuman Kumar, and so many of us. So we need to, in fact, we celebrated that patient's silver jubilee, and he became a volunteer. So this is what a small, group, what is, Sarthi group, we have framed the name, will go. These are the life beyond cancer. These are all, when in 2013 we have, called them, and felicitated them. So it became a real story. Third case, this 28-year-old, no habits, only acid reflux was there, and seen by 4 centers. And as Madam Kaunit was talking about proliferative verrucous hyperplasia, this is the classical case, proliferative verrucous hyperplasia at PVL turning into the malignancy. This is when in 2022 I saw. But before that also it was PVL. In fact, MRI showed 7 millimeter depth of invasion. Still, it was not taken seriously. But biopsy was the answer. When I did the biopsy, it was moderate to moderate differential. And it was excellent surgery by oncosurgeon Dr. Abhidev Vaidya, Abhishek Vaidya. NCI is there are a lot of very good centers, and credit should go to our PM sir, that there are several oncology excellent centers open throughout the India. So this is what we are doing, and after 3 years follow-up, she is with. So her name is Prerna, but still itself an inspiration for me. And over the 3.5 years follow-up, no recurrence. Of course, we need to follow it very carefully. That is our duty, the responsibility of the lateral surgeon, which is given to us by the oncosurgeon after the OT. Because that is, they will remain busy operating cases. We should remain busy following up the cases. And follow-up should be expensive, like 30 years or so on. This is just I wanted to bring. This is the CAVET concept by Tata Memorial Hospital, Professor Badwe, Dr. Anil De Cruz, Pankaj Chaturvedi, they have come out with it. And definitely, aims and objectives are similar. We have also adopted for the Sarthi. And this is the patient navigation concept which we have to imbibe. I am sure our IIOMP and Dr. Anshuman's support of the Sarthi group will come out with very concrete navigating system. So real heroes are, these are the real heroes. But the real hero is the captain of the ship and the stewardess who served the last surviving, in that Titanic storm. So these are the, I told you very proudly, Anil De Cruz, Pankaj Chaturvedi, Anshuman, Abhishek, and so many of us. We need to go to them. They are waiting for us to, serve the humanity. And of course, Sarthi, as you have told, that practice makes a man perfect. And definitely, navigating all these cancer sufferers, families will definitely lead will come out with a beautiful answer, successful answer to the oral cancer. This is what I just wanted to conclude. And this is again thanks to Dr. Daftari sir, Anshuman, Kaur madam, and Devi Shetty, of course, and all of us. And again, I was just thinking about, let me quote, because Anshuman is really poetic. You have seen his multifaceted personality. डूबता है घर कोई तो बढ़ के उसे हाथ दो, डूबता है घर कोई तो बढ़ के उसे हाथ दो. Cancer patient में सिर्फ survival, I mean, in the family there is a storm, financial, economic, emotional, everything. Friends are getting scattered. Nobody wants to, help them properly. But we are so खड़े रहकर ना सिर्फ साहिल से आवाज दो. Don't sit in your dental clinics. Don't just sit in your dental clinics. Go to home or help them wherever possible. This is I have done. And this is I have learned from my institution, whose motto was the service to humanity. And this is just I wanted to conclude with the thanks to organizers, and sorry we were running behind the time. And hopefully, since this is a symposium, there will not be a question. Only one question definitely will be, answered by the panelists. May I invite only one question? Or maybe the compliment. Anybody to offer compliment? Dipto, offer the compliment. This is my order to you. Come. This will go in proceedings. Come. Just a minute. We are winding up because the other session is starting soon.
It's always fantastic, and it was wonderful, and we hope to have these things future in the upcoming conferences also. Thank you all the panelists for this wonderful session. We enjoyed thoroughly.
On behalf of the organizing committee, I extend my heartfelt gratitude to all our esteemed speakers for sharing their invaluable knowledge and perspectives, and to our audience for their enthusiastic participation in making this session a success. Now, as a token of deep appreciation and respect, may I request our keynote speakers, Dr. Anshuman Kumar sir, Dr. Kavneet Kaur ma'am, and Dr. Vinay Hazare sir, to kindly do the honors of felicitating Dr. D.K. Daftari sir. As a gesture of our sincere thanks, we would also like to felicitate our distinguished speakers. May I request Dr. Vinay Hazare sir to felicitate Dr. Anshuman sir. big round of applause for sir, please. May I also request sir to felicitate Dr. Pavneet Kumar ma'am. And now I request Dr. D.K. Daftari sir to felicitate Dr. Vinay Hazare sir. Please give sir a huge round of applause. Thank you, sir.
A very good afternoon. I have an important announcement regarding the elections. We had conducted elections for two posts, that is, one is Vice President and one is Joint Secretary. And as Vice President, Dr. Umesh Chandra was elected with 78 votes. Dr. Govind Rajkumar was elected with 65 votes. And for the Joint Secretary, Dr. Sahana Ashok was elected with 72 votes. Congratulations to all the office bearers. Thank you.
Good afternoon, everybody. We are conducting 23rd National PG Convention at KD Dental College, Mathura. I invite all of you to register today. Today, if you register, you have a concession for postgraduates. It is 4,500. For faculty members, it is 5,000. Please take the advantage of this reduced registration. After this, it is going to be increased. You can contact me or Dr. Ram Mallar. The details are there in the flex. So kindly register.
Now it's time to commence the guest lecture by our esteemed keynote speaker, Dr. Deepak Pandey. We would like to felicitate Dr. Jayanti P. Ma'am. I request President IOMP Dr. S. Vanati Sir and Secretary IOMP Dr. Guru Raj Sir to present, and also Alka Kale Ma'am to present a token of appreciation to Dr. Jayanti P. Ma'am. A huge round of applause for Ma'am, please. Now it is time to commence the guest lecture by esteemed keynote speaker Dr. Deepak Pandya sir on the thought-provoking topic, the evolving landscape of salivary gland tumors, prognostic insights, advances and clinical case discussions. To chair this significant session, may I invite on stage our respected chairperson, Dr. Narveer Singh Thakur sir, Professor and Head, Department of Oral Pathology and Microbiology and Medical Superintendent, Himachal Pradesh Government Dental College and Hospital, Shimla. With over 25 years of teaching experience, sir has led the department since 2009 and made remarkable academic and clinical contributions. Dr. Thakur sir has numerous publications in reputed journals and contributed content on oral cancer for the Directorate of Health and Family Welfare, Shimla. We are honored to welcome Dr. Narveer Singh Thakur sir, a distinguished academician, administrator and leader. A huge round of applause for sir. I request our respected chairperson to kindly proceed with the scientific session and introduce our distinguished keynote speaker, Dr. Deepak Pandya sir.
It is a great privilege to introduce Dr. Deepak Pandya. Dr. Deepak Pandya, he is currently serves as Associate Professor in Research, Head of the Department of Oral Pathology and Microbiology at Savita Dental College and Hospital, Chennai, with over 7 years of academic experience, 149 index publications, multiple patents, and a textbook to his credit. His research in molecular pathology and oncology has significantly advanced understanding of oral cancer. I warmly welcome Dr. Peter Pandya sir to deliver his keynote address today. Thank you.
Thank you, sir. I hope I am audible. Everyone will be hungry by now. I just want to say thanks to the organizing team of IOMT, ITS Dental College, especially Shetty sir and Anshi ma'am. And before I go to the lecture, I just say that salivary gland tumors are the most difficult tumors, I think, for oral pathologists to diagnose when it comes to histology. When you get the slides, everything looks very much similar. All are blue or with hyalinization. Everything looks very, very difficult. And the topic, just don't look into the topic, it's very classy and high-fi, but I'll go very simple. I am Dr. Deepak Pandya, I am Research Head and Associate Professor in Savita Dental College. And so I'll be talking about the classifications and terminology which have been shifted from 2017 to 2024. There has been a massive change. There is updated molecular characterization, definitely yes, and there is some clinical case discussions I will be talking about. So these are the two classifications which I have actually taken the pictures from the books of mine, because I always prefer to get the hard copy of WHO. So if you see, there is a major change here is there is removal of the headings, like the hematopoietic tumors, they have been removed because WHO says they are more into the original classes, like in the blood. So they are in part B. Soft tissue tumors are removed in the separate soft tissue tumor chapter. Non-neoplastic tumors are there, only one tumor has been retained. Sorry, the lesion has been retained. Now if we can see, the major change here is the major change here is like we have a proper organization. When we were in 2017, when I saw the book, I had a major problem. Why malignant first, benign later? Why it is not the non-neoplastic first, then benign, then malignant? So that was solved. I'm very happy. I think everyone is. The second thing is they removed all the ICD codes. I am very comfortable with these ICD codes because they're 0, 1, 2, 3, they speak a lot. If it is benign, it is in situ, it is borderline, it is malignant, it says. For example, if we see here, this cytoblastoma. So we don't know. It is not. It is written under malignant, but it is. We don't know still what is the. There is no molecular classification. There is no characterization. Nothing is done. So it is still a borderline thing. So it's very comfortable to use those spots. But okay, they are gone. The next thing is addition of many tumors like mucinous adenocarcinoma is there, sclerosing microcystic adenocarcinoma is here. In the benign, we can see intercalated duct adenomas, then sclerosing adenomas. They all have been added in the classification. Another major change here is from the non-neoplastic, these adenoses have been shifted to adenoma. Previously, it was adenosis, sclerosing polycystic adenosis. Now it is polycystic adenoma, very fair. It has the role, it deserves to be in the benign tumor. Another thing which was there in the classification is there is one grey zone, that is the intraductal papillary mucinous neoplasm. There is a AKT1 mutation, but there is no solid evidence yet that to be classified with mucinous adenocarcinoma, so they have still not included in WHO 2024. So if we see, this is the 2017 classification. Wherever I have put the crosses, no molecular characterization was done. Only here we have benign tumors, we see here we have one pleomorphic adenoma. In malignant, the same old ones, the mucodermoid, adenoid, SLE, the same ones which we had for years. But when we shifted to 2024, these are the still those benign and malignant tumors where we have no molecular change yet. It is not reported yet. But this is the latest scenario of the malignant tumors. This is the chapter of molecular thing from the book which I have covered and clubbed together into one chart so that it will be easy to understand that if we see consistently FLAG1, HMG1, and these are actually shown by pleomorphic adenoma, the malignant counterpart of that, salivary duct carcinoma, myoepithelioma, myoepithelioma. So these all have this common, very true, what you call the molecular characterization. They have been proven again and again. Salivary duct carcinoma, if we see there are lots are there, but if we see to mucodermoid, one is the passive one, mammal one. With that, there is one which is sharing it with salivary duct carcinoma. Similarly, basal cell adenoma, basal cell adenocarcinoma. Basal cell adenoma has more molecular features rather than basal cell adenocarcinoma, which shows only CY-ILD. Similarly, the major change happened here was the intraductal carcinoma. Intraductal carcinoma is one actually very difficult case if we see to report, or it is a very easy case. All we need is few IHC markers and the molecular features. See, all the molecular things, so many things are there, but very clear line has been written in WHO. It is being followed in the high income countries. We cannot follow this for all the cases. It is very difficult to follow all these things. But there are something which we still follow in our labs, that is IHC. We'll come to that after some slides when we see. So now I'll show some cases, only 5 are there. The first case, a very, 33-year-old male patient, there was a bony heart swelling in the lower jaw. No habits, nothing. It was very bony heart. X-ray was taken, it looked very much well defined, but unilocular to multilocular, it is like a fine lesion. So for such a lesion, what will think? Ameloblastoma OKC. For the case history, we tell the students to add more, what more GOC, COC. Not needed actually, I feel. I always consider to be more precise. See, the root resorption can be either I thought ameloblastoma but OKC. Incisional biopsy was taken, it was nothing, it was something else, it was more of a clear cell neoplasm. Bone, you can see, as we go to the higher power, we can see the predominant population here is a clear cell with well-defined borders and eccentric nucleus. Amongst that, we have lots of cells which are squamoid in nature with well-defined borders. So it was a clear-cut case. We don't have to go for much molecular thing. It is a clear cell variant of mucodermoid carcinoma. So we see the cases when we least expect the cases. For this, ISC was done because the closest differential diagnosis comes here is the GOC. Especially on small biopsies, GOC has to be ruled out. Central MEC and GOC is very well, like closely we have to monitor. So we have done one study and I found that CK7 and CK8 works very well to differentiate these two lesions, MEC and GOC. CK7 if we see in MEC, it will be diffuse. CK8 we see, it is totally diffuse. But when it comes to GOC, we'll see only the surface layer of the epithelial lining positive for this. So that is very helpful. What we did some molecular profiling. We went into NGS and GOC was used as a control. In this NGS, we used 50 gene panel. MAML2 was not included, that is well established. So we did not, it's a little costlier thing. So we did not ask the patient to do B paid. So I wanted to know what is the molecular profiling. So GOC I used as a control and it was found that GOC showed all these PIK, 3CA, KRAS, TP53, MET, EGFR, but none of these was found in central MEC. So definitely they are totally different entities. We should not go like GOC converting into MECs. I don't think that happens. It is a separate thing. So I believe, like personally, it should not be considered. So it was a KSL variant of central mucopolysaccharidosis carcinoma. Resection was done. There was no recurrence after 17 days. There are some criteria we should always follow. That is, the cortical plate should be intact. Radiographically, there should be evidence of bone destruction. Histologically, you should confirm, exclude all the primaries, do pass. Closest differential diagnosis, clear cell odontogenic carcinoma, metastasis usually does not happen into the bone, it is more to the soft tissue, and GOC particularly in the small biopsies. So definitely MML2 is positive for mucoepidermoid. You can use CK19. I found CK19 is positive in both. So I cannot say the odontogenic origin of MEC and GOC. CD10 and bimentin are very helpful markers because they are readily available in the lab for. Despite being RCC as epithelial, it will express CD10 and bimentin both. Then CK7 and 8 I found very helpful. CK7 and 8 are very localized on the surface in GOC and very diffuse in central MEC. Coming to the second case, it was a second opinion biopsy. We got only the slide, so that was moderately differentiated squamous cell carcinoma operated, and we got the specimen of glossectomy, complete glossectomy with 1B. So it was 42 years old male patient. With that, it was found that in MRI there was one T1 lesion in the lateral border of the tongue which crossed the midline, and there was a deep infiltrative tumor of the parotid. For this patient, because we had a longer queue for the thing, like wait period, so patient received oral metronomic chemotherapy with these 3 drugs. We got the salivary tumor also. There was a white tan solid tumor in the salivary gland. So what we found, the tumor of the tongue was a poorly differentiated squamous cell carcinoma, extremely poorly differentiated with multiple PNI. When the nodes were examined, there was extranodal extension, but the googly was there in the salivary gland tumor. That was something else. It was showing a cystic neoplasm with lots of conchoidal necrosis, with pattern, but it is not confined to these areas. It is definitely infiltrating into the stroma. So it is not a very intraductal type of neoplasm, it is infiltrated. So for this, we did first thing I always prefer is doing a chi, whether it is actually tumor. So it was very high. Then I went for HER2 and AR. Both were very strongly positive. A case was diagnosed as synchronous salivary duct carcinoma with squamous cell carcinoma. So it was a poorly differentiated squamous cell carcinoma with T4A, 3B and T2 of salivary duct carcinoma. I found there was one only recently, 2025, one case was reported where synchronous salivary duct carcinoma and SCC were seen, but there are other cases with MEC, Watson tumor, so many are there. With salivary duct, I found only one case. The good thing is the use of targeted therapy for AR for salivary duct carcinoma, and these are the markers we should always go for salivary duct carcinoma. Most of the time it should be AR. And unlike intraductal carcinoma, so this S100 and SOX10 are usually negative. The case 3 was something very bluish lesion of the retromolar region of the right side in a 25 years old female patient with CT, it was found that there was a mass in the parapharyngeal space, in the anterior segment. So for such lesions, for such tumors, we have to find whether it is in the anterior segment or in the posterior segment. If it is the anterior segment, most of the time these are lymphomas or the salivary gland tumors or the lipomas. If these are there in the posterior segment of parapharyngeal space, they are mostly arising from the nerves or lymphomas. So FNAC was done. It was very much like showed mainly the mucinous material and the mucinophages, but only one cluster I could found which showed one cluster, very suspicious cluster of highly pleomorphic cells. So incisional biopsy was done thereafter. It showed one cystic lesion with subepithelial hyalinization. If we go to higher power, we see lots of microcystic spaces with apocrine features. There was one single cystic tumor was seen in the wall also. Pass positive in the mucous cell, acid blue was positive. Diffusely it was CK7 positive, and the P63 was just lying, a basal layer was intact. At this point of time, again we could just give a malignant salivary gland tumor. There are so many tumors because the biopsy was very small. After these two markers, the tissue got exhausted during cutting. So we directly went for frozen. In the frozen sections, what we found that the tumor was actually like a big cystic, looked like somewhere between the intraductal salivary duct or maybe the mucodermoid with wide areas close to the muscles. It was actually going near the muscles. And finally we got the excision thing. In the excision we can see micropapillary areas of the cystic, the micropapillary arrangement of the tumor cells with lots of apocrine features which we see very closely. The nuclei are large, they have very prominent they have vesicular nuclei with prominent nucleoli and where lots of some areas were cuboidal. Diffusely CK7 positive. When we did P63, it was showing just the intraductal component. There was no infiltrated part. Ki was very low. Then we did S100, which was negative, and AR was done, which was diffusely positive. So it was reported as the apocrine variant. It was a case in 2021. There was no apocrine or intercalated was not there. So we just reported as intraductal carcinoma of minus salivary gland. So 2025, recently in April, the patient came back. This is the X-ray which is of 2021. There is no only one tooth is there and no changes in the bone. When we see here, there was some erosion was seen on the bone. So at this point of time, after 4 years, the patient came. When we did P63, the layer was not intact. It was no longer intraductal. It was carcinoma arising from intraductal carcinoma. It was reported like that and was referred to a cancer center. So these are the 4 variants of intraductal carcinoma. I usually prefer we should always do S100, E63 and AR. These 3 markers will help to differentiate in all these subcategories of intraductal carcinoma. This is a case 4, which is again a very smooth surface swelling of the hard palate. But again, it was so much clear with so much plastic stroma. When we see the cells, they are very much clear. So, very straightforward diagnosis if we say if we are not going to torture the PGs that tell me the differential diagnosis, I will say this is a very straightforward case. A clear cell carcinoma, hyalinizing variant of clear cell carcinoma. We can see the P63 is enough. We can see the tumor and the surface epithelium, there is no connection. It was totally normal, no dysplasia. But we can see basal and parenchymal, definitely will take P63. So it was a clear-cut case of clear cell carcinoma, but I am showing 2 scenarios, our cases only. One is very much similar looking clear cell odontogenic carcinoma, with which it will share the molecular profiling. And another is renal cell carcinoma, mostly comes to the tongue, not to the hard palate, but still very much similar histologically. That we should definitely consider. We found that at exon 7 there was a mutation in EWSR1. So it was classified as clear cell carcinoma of left palate.
we always go for P63. P63 is always positive in clear cell carcinoma. It is a good thing is it's a low-grade tumor, just exercise, it will not come back. And finally, one last case where I don't think we need more of markers or something, but definitely a high grade of suspicion. It was one ulcerated lesion of the floor of the mouth. The only history was an abutment was placed in the adjacent floor. Incision biopsy was taken, the surface was ulcerated, we could see some islets in the subepithelial area and salivary gland. It was very, very close to the salivary gland. But when we go closer, it was little bland. Good thing was, there were changes in the salivary gland. I felt good thing, there is no malignancy. But somewhere we are oral pathologists, something is there in the mind, rule out, rule out, rule out. What we do, excision was done. This is after 1 week. This is the lesion only remaining. That ulcerated lesion after 1 week, only this much remained. There was pseudoepitheliomatous, the excisional biopsy. Pseudoepitheliomatous hyperplasia is there. Still there is those spindle-shaped proliferation is there. Again, something comes. We know it is endothelial cell proliferation. But what if it is something poorly differentiated? That thing definitely remains. There was coagulative necrosis very quickly here and there. So we did one marker like to rule out whether that is tumor cell or endothelial cells. It was CD34 positive. There is no infiltration. TI was very low, and finally we gave it as diagnosis of necrotizing chalometaplasia of floor of mouth. This was published in JADA recently. And here what we need is clinically and histologically we need very high suspicion for such lesions. And finally I'll conclude that for salivary gland tumors, histomorphological evaluation is more important. With that, definitely special stains, particularly for some pathologies, and INCs for differentiation, close differentiation like if we have cellular pleomorphic adenoma and adenoid cystic carcinoma and polymorph adenocarcinoma, benign, low grade, high grade. For that, P63, P43, very minimal, but they help. And molecular characterization is ongoing. It may take few more years, at least in India, because at least they are very expensive. And thank you for listening to me. This is my college.
Thank you, Dr. Deepak, for updating us on the revised classification and current prognostic markers of salivary glands. Thank you. Thank you.
Thank you very much, sir, for that truly enlightening presentation. I now request our chairperson to felicitate our esteemed keynote speaker, Dr. Deepak Pandya, sir. Let's give him a warm round of applause. Moving ahead, I invite Dr. Punya Angadi ma'am, Professor, Department of Oral and Maxillofacial Pathology, KLE Academy of Higher Education and Research, Belagavi, to felicitate our chairperson, Dr. Narveer Singh Thakur, sir. A huge round of applause for sir, please. We shall continue with our valedictory ceremony in another 2 minutes. I request all the delegates to remain seated.